Okay, so, if you've been told you have Sjogren's, or someone you love has, or you've just been chasing down why your eyes and mouth feel like the Sahara for no reason anyone can explain, I want to slow down and actually walk through this with you. Not the quick version. The whole thing. Because most people, even people who've been living with this for years, only ever get half the picture. There isn't just Sjogren's. There are two real, distinct categories, primary and secondary, and the difference between them isn't just a label your rheumatologist writes on a chart. It changes what's actually happening in your body, what else might be going on underneath the surface, and what your symptoms are trying to tell you. So let's go through it properly. Hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Inside is 200,000 subscribers, and every single person who joins moves us closer. And if you want the full Sjogren symptom map guide with visuals, symptom breakdowns, and additional resources, type symptom map in the comments, and I'll send you the link to access it. Before we split it into primary and secondary, we need to get clear on the foundation, because a lot of the confusion people have about Sjogren's comes from skipping this part. Sjogren syndrome is an autoimmune condition. That means your immune system, the system whose entire job is to identify threats and attack them, has gotten confused about what counts as a threat. Instead of only going after viruses, bacteria, and other invaders, it starts treating some of your own tissue like it's the enemy. In Sjogren specifically, the primary targets are your moisture-producing glands. Mainly your lacrimal glands, which make tears, and your salivary glands, which make saliva. Your immune system sends white blood cells, specifically lymphocytes, into these glands, and over time, that immune activity damages the gland tissue and interferes with its ability to do its one job: keep you moist where you're supposed to be moist. That's why the two symptoms almost everyone associates with Sjogren's are dry eyes and dry mouth. Doctors even have shorthand for it, Sika syndrome, from the Latin word for dry. But, and this is the part that gets lost constantly, Sjogren's is not just a dryness disease. It's a systemic autoimmune disease, meaning it can affect joints, skin, lungs, kidneys, nerves, and blood vessels too. The dryness is just the most visible, most universal symptom. It is very often not the only one. So when we talk about primary versus secondary Sjogren's, we are not talking about mild versus severe. We are talking about what's going on around it. If any part of this section landed for you, the years of being told it's just dryness, the sense that there's more going on than anyone's named yet, type the word understood below. Just that. Let it be a small proof to yourself that you get it now, even if no one explained it to you before. Primary Sjogren's is the version where Sjogren's is the main event. It's not riding along with another autoimmune disease, it stands on its own. Your immune system has singled out your glands, and sometimes other tissue, without another separate autoimmune condition sitting alongside it. Here's the contrast worth sitting with for a second. For a long time, dryness got waved off as just getting older, or just allergies, or you're probably just dehydrated, drink more water. That's the old belief a lot of people are still carrying around. But actual, persistent, disruptive dryness, the kind where you wake up and your eyes feel like sandpaper, or you can't get through a meal without water because your mouth won't produce enough saliva to swallow normally, that is not a normal aging symptom. That's often the first visible sign of primary Sjogren's quietly building for years before anyone puts a name to it. Who tends to get it? Primary Sjogren's shows up overwhelmingly in women, somewhere around 9 out of every 10 diagnosed cases. It most commonly gets diagnosed somewhere between the 40s and 60s, though it absolutely can appear earlier, and there are documented cases in much younger people, including, rarely, children. If it's showing up younger, it often gets missed longer, because doctors aren't trained to expect it in a 28-year-old. The core symptoms of primary Sjogren's. Let's go one by one, because the details matter more than the summary. Dry eyes, keratoconjunctivitis sicca. This isn't "my eyes feel a little tired." It's a gritty, burning, foreign body sensation, like there's sand under your eyelid that never goes away. Some people describe it as feeling like their eyes are on fire by the end of the day. Left untreated long enough, chronic dry eye from Sjogren's can actually damage the surface of the cornea, because tears aren't just for comfort, they're doing constant, quiet maintenance on the eye's surface. Dry mouth, xerostomia. Saliva does more work than people realize. It helps you taste food, swallow, speak clearly, and, critically, it protects your teeth. When saliva production drops, people with Sjogren's often develop a distinct pattern of dental decay, frequently right at the gum line, because saliva isn't there anymore to buffer the acids and wash away bacteria. Many people with primary Sjogren's describe needing water constantly just to get through a sentence, or waking up multiple times a night because their mouth is so dry it wakes them up. Dry everything else, honestly. The gland involvement doesn't politely stop at eyes and mouth. Many people also experience dry, irritated skin, vaginal dryness, which can affect intimacy and comfort significantly, a chronic dry cough, from dryness in the airways, dryness in the nasal passages, sometimes leading to nosebleeds, profound fatigue. This is one of the most underestimated parts of primary Sjogren's, and one of the most invalidated. It's not "I didn't sleep well" tired. It's a deep, whole-body exhaustion that doesn't resolve with rest, and it can be just as disabling as the joint pain or the dryness, sometimes more so. It's also one of the hardest symptoms to prove to other people, because fatigue doesn't show up on a scan. Joint pain and stiffness. Many people with primary Sjogren's experience aching, stiff joints, especially in the hands, wrists, and knees. It can look a lot like early rheumatoid arthritis on the surface, which is part of why the two conditions get confused early in the diagnostic process. More on that in a minute. Swollen salivary glands. Some people notice visible swelling around the jaw or in front of the ears. This is the parotid gland, one of the major salivary glands, reacting to the ongoing immune activity. Where primary Sjogren's can go beyond dryness. This is the part almost nobody explains clearly, and it's the piece that actually matters most for long-term health, not just day-to-day comfort. Primary Sjogren's is capable of affecting organs beyond the glands. Doctors call these extraglandular manifestations, and they include lung involvement, dryness in the airways or, less commonly, actual lung tissue inflammation. Kidney involvement, a specific pattern of kidney issue called interstitial nephritis, or in rarer cases, difficulty with the kidneys regulating acid balance in the body. Nerve involvement, numbness, tingling, or burning sensations, particularly in the hands and feet, from a condition called peripheral neuropathy. Vasculitis, inflammation of small blood vessels, sometimes showing up as a distinct purple-red rash on the lower legs. Lymphoma risk, this is the one that deserves to be said clearly and without softening it. People with primary Sjogren's have a meaningfully higher lifetime risk of developing a type of blood cancer called non-Hodgkin lymphoma compared to the general population. It's still a minority of people with Sjogren's who develop it, but it's real enough that persistent swollen glands, unexplained weight loss, or ongoing fevers in someone with Sjogren's always deserve a proper look, not a shrug. That last point isn't meant to scare you, it's meant to arm you. Knowing this exists means you and your doctor can actually watch for it, instead of it catching anyone off guard. If reading through primary Sjogren's symptoms felt like someone finally describing your own body back to you, type the word recognized. You've spent a long time explaining this to people who couldn't picture it. Let this be one place where it's already understood. Now here's the fork in the road. Secondary Sjogren's is when Sjogren's shows up alongside another autoimmune disease that's already established, or that gets diagnosed around the same time. It's not less serious Sjogren's. The word secondary refers to timing and company, not severity. The most common autoimmune conditions that travel with secondary Sjogren's are rheumatoid arthritis. This is the single most common pairing. Systemic lupus erythematosus, lupus. Systemic sclerosis, scleroderma. Less commonly, conditions like mixed connective tissue disease or certain thyroid autoimmune conditions. The mechanism is the same underlying idea, lymphocytes infiltrating the glands, gland damage, dryness, but the surrounding picture is different because there's already a separate autoimmune process going on that has its own symptoms, its own antibody signatures, and its own treatment plan that has to be considered alongside the Sjogren's piece. Why the distinction between primary and secondary actually matters. Here's the thing worth sitting with. If you already have RA or lupus, and dryness starts creeping in, it is incredibly easy for both you and your doctor to just assume it's a side effect of the other disease, or a medication side effect, and let it go unaddressed. That's the trap. Secondary Sjogren's often gets caught later than primary Sjogren's, precisely because everyone's attention is already on the first diagnosis. The dryness gets treated as background noise instead of its own condition that deserves its own management plan. This is also why doctors will often run a specific panel of tests, antibodies like anti-Rho SSA and anti-La SSB, an eye test called Sjögren's test that measures tear production, and sometimes a small lip biopsy to look at the salivary gland tissue directly, even in someone who already has a confirmed autoimmune diagnosis. It's not redundant. It's because these two conditions can and do coexist, and each one needs its own attention. How the symptom picture differs in secondary Sjogren's. The dryness symptoms themselves, dry eyes, dry mouth, fatigue, look extremely similar to primary Sjogren's. What differs is the background noise the symptoms are competing with. In eye-associated secondary Sjogren's, joint symptoms tend to be more pronounced, more symmetrical, and more likely to involve visible joint swelling and, over time, joint damage, because eye itself is actively attacking joint tissue, separate from whatever joint aching Sjogren's contributes on its own. In lupus-associated secondary Sjogren's, you're more likely to see the wider lupus symptom set layered on top, the distinctive facial rash, sensitivity to sunlight, more prominent kidney involvement, and a broader pattern of fatigue and joint pain that swings with disease flares. In scleroderma-associated secondary Sjogren's, skin thickening and tightening, Raynaud's phenomenon, fingers turning white or blue in the cold, and digestive symptoms tend to be the dominant additional features laid over the dryness. So the honest, most useful way to think about it, primary Sjogren's is Sjogren's symptoms on their own canvas. Secondary Sjogren's is Sjogren's symptoms painted onto a canvas that already has another autoimmune picture on it, and figuring out which symptom belongs to which condition is a genuinely difficult, ongoing puzzle that takes a good rheumatologist and real patience. If you're managing Sjogren's alongside another autoimmune condition and you've ever felt like your dryness or fatigue got treated as an afterthought, type the word valid. Two conditions, both real, both yours to name, you don't have to pick which one gets to matter. Here is how both types actually get diagnosed. Whether it's primary or secondary, the diagnostic path leans on a similar toolkit, because the underlying gland damage looks the same under a microscope. A typical workup includes blood tests for specific antibodies, anti-Rho SSA and anti-La SSB are the classic markers, present in a majority of Sjogren's cases, though not everyone tests positive for them. Rheumatoid factor and ANA, antinuclear antibody, are often checked too. Sjögren's test, a small strip of paper placed at the edge of the eyelid to literally measure how much tear fluid is produced over 5 minutes. Salivary flow testing, measuring how much saliva is produced over a set period. A lip biopsy, a minor procedure taking a tiny sample of minor salivary glands from the inner lip, examined under a microscope for the telltale pattern of lymphocyte clustering. A full review of other symptoms and existing diagnoses. This is where the primary versus secondary distinction actually gets made, by looking at whether another autoimmune condition is already present or emerging alongside it. No single test diagnoses Sjogren's on its own. It's a picture built from several pieces, which is part of why diagnosis, on average, takes years from first symptom to confirmed diagnosis. If that's been your experience, it is not because you did anything wrong or explained it poorly. It's because this disease is genuinely difficult to pin down, even for good doctors. If you've been through test after test looking for an answer, and it's felt like a long, tiring road, type the word patient, for the patience it's taken you to get here, and as a quiet reminder that you're still a patient worth answers, however long this has taken. Let's slow down even further here, because symptoms differ is a vague sentence, and vague sentences don't help you actually recognize what's happening in your own body. Let's put primary and secondary Sjogren's next to each other, symptom category by symptom category. Dryness itself. In both types, the dryness symptoms, eyes, mouth, skin, nasal passages, tend to look nearly identical, because it's the same gland damage happening through the same mechanism. If you lined up someone with primary Sjogren's and someone with secondary Sjogren's and only looked at their dryness complaints, you likely couldn't tell them apart. This is actually one of the most important things to understand. The secondary label is not about the dryness being milder or different. It's entirely about what else is going on. Fatigue. In primary Sjogren's, fatigue tends to be attributed, eventually, directly to Sjogren's itself, once other causes are ruled out. In secondary Sjogren's, fatigue is trickier, because it can be coming from Sjogren's, from the paired condition. Lupus and IA both cause significant fatigue on their own, from medication side effects, or from some combination of all three. This is part of why fatigue in secondary Sjogren's often takes even longer to get taken seriously, it gets passed back and forth between "that's probably your lupus" and "that's probably your Sjogren's" without anyone fully owning it. Joint symptoms. This is one of the clearest points of divergence. In primary Sjogren's, joint pain tends to be more of an ache, stiff, uncomfortable, often worse in the morning, but usually without the visible swelling, joint erosion, or long-term joint damage you see in true inflammatory arthritis. In eye-associated secondary Sjogren's, you're dealing with an actual erosive arthritis process happening at the same time, meaning the joints themselves can be damaged over time if the IA isn't well controlled, separate from whatever ache Sjogren's contributes. Skin. Primary Sjogren's mostly affect skin through dryness, rough, flaky, itchy skin. Secondary Sjogren's paired with lupus can bring the distinctive facial rash and photosensitivity that lupus is known for. Paired with scleroderma, skin can become thickened and tight, especially on the fingers and face, which is an entirely different mechanism from ordinary dryness. Circulatory symptoms. Raynaud's phenomenon, fingers or toes turning white, then blue, then red in response to cold or stress, can show up in primary Sjogren's on its own, but it's especially common and especially pronounced in secondary Sjogren's paired with scleroderma or lupus. Organ involvement. In primary Sjogren's, when organ involvement happens, it's happening because of Sjogren's itself, the lungs, kidneys, or nerves being affected directly by the same immune process attacking the glands. In secondary Sjogren's, organ involvement can come from either condition, or both at once, which is why care teams managing secondary Sjogren's often need to coordinate closely between a rheumatologist managing the primary autoimmune disease and specialists watching the specific organ systems involved. Antibody patterns. Both types often show anti-Rho SSA and anti-La SSB antibodies. But secondary Sjogren's will typically also show whatever antibody pattern is associated with the paired condition. Rheumatoid factor and anti-CCP antibodies in RA, anti-dsDNA, and anti-Smith antibodies in lupus, anti-centromere or anti-SCL70 antibodies in scleroderma. Reading someone's full antibody panel is often how a rheumatologist first starts to suspect that more than one autoimmune process is happening at once. The through line across every single one of these differences. Primary Sjogren's gives you a cleaner, more contained symptom picture to work from. Secondary Sjogren's gives you overlapping, tangled symptoms that require careful separation, which is exactly why people with secondary Sjogren's often describe feeling like their symptoms get absorbed into their other diagnosis instead of being addressed on their own terms. If untangling which symptom belongs to which condition has felt like its own exhausting job on top of everything else, type the word clarity. You deserve to understand your own body without having to fight for the explanation. If you or someone you know has gone years bouncing between doctors before getting a Sjogren's diagnosis, you are far from alone in that. A few real reasons this happens, worth understanding rather than just accepting as an unexplained frustration. The symptoms are common on their own, and rare in combination. Dry eyes alone? Extremely common, usually unrelated to autoimmune disease. Fatigue alone? Extremely common, usually unrelated to autoimmune disease. It's the combination, over time, along with specific test findings, that starts pointing toward Sjogren's. Any one symptom in isolation rarely raises a flag. Sjogren's doesn't always show up the same way twice. Some people have severe dryness and mild systemic symptoms. Others have relatively mild dryness but more pronounced joint or organ involvement. There isn't one single typical presentation, which makes it harder to pattern match quickly. Primary care often isn't equipped to catch it early. Dry eye and dry mouth get treated symptomatically for a long time. More artificial tears, a referral to an eye doctor, maybe a dentist visit, before anyone connects those dots to a systemic autoimmune process and refers to rheumatology. In secondary Sjogren's, attention is already elsewhere. As covered above, when you already carry a lupus or RA diagnosis, new dryness symptoms are easy to file under side effect, or just part of my existing condition rather than getting investigated as their own separate diagnosis. Antibody-negative Sjogren's exists. A meaningful portion of people with Sjogren's don't test positive for the classic anti-Rho, anti-La antibodies, which can delay diagnosis further and sometimes requires leaning more heavily on the lip biopsy and clinical picture rather than blood work alone. None of this is a reflection of you being unclear, difficult, or too much. It's a reflection of how genuinely complex this disease is to isolate, even under ideal conditions with an attentive doctor. If you've ever worried you were too much for bringing up symptoms doctors couldn't explain right away, type the word enough. You were never too much. You were asking exactly the right questions before anyone had caught up with an answer. There's a layer to living with either type of Sjogren's that doesn't get talked about nearly enough, and it deserves real space here rather than a passing mention. Chronic dryness sounds, on paper, like a minor inconvenience. In daily practice, it reshapes ordinary life in 100 small ways. Eating a meal without enough saliva to comfortably swallow. Speaking for long stretches, teaching, presenting, even just having a long conversation, becoming physically uncomfortable. Sleep getting interrupted, night after night, by a mouth so dry it wakes you. Eyes that burn under office lighting, or in wind, or on a screen for too long, until you start quietly avoiding situations you used to enjoy simply to protect your eyes for the rest of the day. Layer fatigue on top of that, and you get a condition that is exhausting in a very literal sense, but also isolating, because it's largely invisible. Nobody looking at you can see how dry your mouth is or how heavy your fatigue feels. That invisibility is part of why so many people with Sjogren's describe feeling like they have to justify or prove their symptoms, over and over, to doctors, co-workers, even family. If that's resonated with you at all while watching this, that feeling of having to explain, prove, or minimize what your body is actually going through, that reaction is worth paying attention to. It's common. It's valid. And it's one more reason a proper diagnosis, whichever type it turns out to be, matters, not just for treatment, but for having a name for what you've been carrying, and permission to stop minimizing it. If you've quietly stopped doing things you love just to protect your eyes, your energy, or your comfort, type the word seen. Not everyone notices what that costs you. But it's real, and it counts. Neither type of Sjogren's currently has a cure, but both are manageable, and management looks pretty similar across both types, layered with whatever treatment the secondary condition requires. Common approaches include artificial tears and lubricating eye drops, sometimes prescription-strength anti-inflammatory drops for more significant dry eye. Saliva substitutes, sugar-free lozenges, and prescription medications that stimulate whatever salivary function remains. Rigorous dental care, because of the elevated cavity risk from reduced saliva. Hydroxychloroquine, commonly used to help with fatigue and joint symptoms. Immunosuppressive medications, used more in cases with significant organ involvement or in secondary Sjogren's where the paired condition also requires them. Lifestyle adjustments, humidifiers, avoiding dry or windy environments, staying deliberate about hydration, pacing activity around fatigue rather than pushing through it. None of this erases the disease. What it does is give you back some control over a body that has felt, for a lot of people, completely out of your hands. If you're actively managing this, the drops, the dental visits, the pacing, all of it, and some days that alone feels like a full-time job, type the word strength. Managing a chronic illness well, day after day, is its own kind of strength, even on the days it doesn't feel like it. If you're watching this not because you have Sjogren's yourself, but because someone in your life does, a partner, a parent, a friend, here's what actually helps, based on what people living with this consistently say they need. Believe the fatigue, even on days it doesn't show. Someone with Sjogren's can look completely fine and still be running on empty. The disease doesn't always look like anything from the outside. Don't minimize the dryness. Just drink more water doesn't fix Sjogren's dry mouth or dry eyes. The problem isn't hydration, it's gland function. It can come across as dismissive even when it's meant kindly. Understand that symptoms fluctuate. Good days and bad days can look wildly different from each other, and that's not inconsistency or exaggeration, it's how autoimmune disease actually behaves. If it's secondary Sjogren's, don't assume it's covered by the other diagnosis. Someone managing lupus or RA and also dealing with Sjogren's is managing two things, not one thing with an asterisk. Both deserve to be acknowledged. Small, practical support goes a long way. Reminding someone to bring eye drops, being patient during a meal if they need extra water, not taking it personally if plans need to shift around a bad fatigue day. These things matter more than they might seem. If you're here because you love someone going through this and you just want to get it right for them, type the word devoted. Showing up to actually learn this, instead of guessing, is exactly the kind of support that matters most. Is Sjogren's the same as just having dry eyes or dry mouth from aging or medication? No. Plenty of things cause dryness: aging, certain medications like antihistamines or antidepressants, other health conditions. Sjogren's is specifically an autoimmune process attacking the glands themselves. The distinction matters because Sjogren's-driven dryness needs to be evaluated in the context of a broader autoimmune workup, not just treated with more eye drops and left at that. Can primary Sjogren's turn into secondary Sjogren's later? Not exactly, but it is possible for someone with primary Sjogren's to later develop a separate autoimmune condition like IA or lupus, at which point their overall picture would start to resemble what's seen in secondary Sjogren's, even though the original Sjogren's diagnosis doesn't change categories on its own. This is part of why ongoing monitoring matters, even once you already have a diagnosis. Is one type more dangerous than the other? Neither type is inherently worse. Primary Sjogren's carries its own considerations, including the elevated lymphoma risk mentioned earlier. Secondary Sjogren's carries whatever risks come with the paired condition, on top of the Sjogren's itself. Severity really depends on the individual case, how much organ involvement there is, how well things are being monitored and managed, far more than which category someone falls into. Do men get Sjogren's? Yes, though far less frequently than women. When men are diagnosed, it's sometimes caught later, partly because doctors are trained to expect this disease in women and can be slower to consider it in male patients presenting with dryness or fatigue. Can Sjogren's be prevented? No known prevention exists, because like most autoimmune conditions, it results from a combination of genetic predisposition and environmental triggers that aren't fully mapped out yet. What can be managed is catching it early and staying ahead of complications through consistent monitoring. If any of these questions were ones you've been quietly sitting with yourself, type the word answered. Getting even a little more clarity on something that's followed you around unexplained is worth acknowledging. Bringing it all together. So here's the shape of the whole thing, side by side. Primary Sjogren's stands on its own. It's the immune system targeting the glands, and sometimes other organs, without a separate autoimmune disease running alongside it. The symptom picture is dryness, fatigue, joint aching, and the possibility, worth monitoring, not fearing, of extraglandular involvement including a raised lymphoma risk. Secondary Sjogren's shows up in the company of another autoimmune condition, most often rheumatoid arthritis, lupus, or scleroderma. The gland damage and dryness are essentially the same process, but the surrounding symptom picture is shaped heavily by whatever the paired condition is doing, which makes diagnosis trickier and makes it easy for the dryness to get overlooked as just a side effect of the other disease. Same root cause. Different company it keeps. And that difference is exactly why it matters which one you or someone you love is actually dealing with, because it changes what your care team should be watching for, testing for, and treating alongside it. Health Inside closing. If you've made it this far, I want to say something directly to you, not to the audience. Living with a body that's doing something confusing, something invisible to everyone else, something that takes years to even get a name, that is genuinely hard. Harder than most people around you probably understand. You are allowed to be tired. You are allowed to grieve the parts of your body that don't work the way they used to. And you are allowed to take up space asking for real answers, even when it takes a long time to get them. Whatever today has been like for you, however your body is feeling right now, you are not alone in this, and you are seen. Take care of yourself today, in whatever small way you can.